Hello, dear students. Two topics today. The first topic, diphtheria in children, and second topic is mumps in children. We will start with diphtheria in children. Diphtheria is an infectious disease caused by bacterium Corynebacterium diphtheria. It infects the throat and upper airways and produces a toxin affecting other organs. Diphtheria affects the children aged 1 to 5 years of age, mostly during their colder month. In this infographic, you can see this information about diphtheria. Diphtheria is an acute toxin-mediated disease caused by Corynebacterium diphtheria. Diphtheria organisms usually remain in their superficial layers of respiratory mucus, including local inflammatory reaction. The organisms may virulence illness in its ability to produce the potent 62 kilodalton polypeptide exotoxin, which inhibits protein synthesis and causes local tissue necrosis. This is a very important factor, local tissue necrosis. Corynebacteria diphtheria. It is the gram-positive, encapsulated, unencapsulated, non-motile, non-sporulating bacillus. It is a characteristic club-shaped bacillary appearance and typically form clusters of parallel rays. Different microbacteriological media for isolation of Corynebacteria diphtheria may be used, most often medium with telluride. Corynebacteria has four biotypes: gravis, metis, intermedius, and belfanti. All strains may produce toxin and can cause severe disease. All isolates of Corynebacteria diphtheria should be tested for toxigenicity. There are different types of Corynebacteria, such as non-pathogenic, non-toxigenic, and toxigenic. Very dangerous toxigenic strains for children and for people. In this graphic, you can see mobility diphtheria, orange line such as is in India, and in last years mobility main not very high, 1, 2, 3, 5 and any cases in here, but this disease important in our days. And in this graphic, you can see how to decrease mobility according to vaccination. When we have vaccination about 97% and mobility decrease for less cases. Signs and symptoms. In more than 90% of patients, the primary foci of diphtheria infection are tonsils or pharynx. The nose and larynx are the next most common sites. After the average incubation period of 2 to 4 days, very short incubation period, local signs and symptoms of inflammation develop. Fever is rarely higher than 39 degrees of Celsius, and there is different forms according to localization of pathologic process. There is classification of diphtheria. Diphtheria classified based on site of disease, and there are anterior nasal diphtheria, pharyngeal or tonsillar diphtheria, laryngeal diphtheria, cutaneous diphtheria, ocular diphtheria, and genital diphtheria. Different types, different localization. Anterior nasal. The infection is localized to the anterior nasal area and is manifested by unilateral or bilateral serous or serosanguinous discharge that erodes the adjacent skin, resulting in small crusted lesions. The membrane may be seen in the nose. What symptoms, what signs for anterior nasal? Characterized moderate intoxication, subfebrile condition, rhinitis, mucopurulent or sanguinous discharge. Symptom, champagne splashes. Nasal passages are narrowed on the nasal septum, erosion, sores, or within membranous plaque. Tonsillar and pharyngeal diphtheria. It is very often localization on this disease. Symptoms in this form of diphtheria begin with a sore throat, usually in the absence of systemic complication. Fever, it is usually lower than 102 degree of Fahrenheit, and malaise, dysphagia, and headache, and not prominent features. Membrane formation grows to involve the pharyngeal walls, tonsils, uvula, and the soft palate. The membrane may extend to the larynx and trachea, causing airway obstruction and eventual suffocation. Underlying tissue of the throat and neck becomes edematous. Lymphadenopathy develops. Mactedema of the neck may lead to bull neck appearance with a distinct color of swelling. The patient throws their head back to relieve pressure on the throat and larynx. Swallowing may be made difficult by unilateral or bilateral paralysis of the muscles of the palate. The degree of local extension of the disease directly correlates with profound prostration, bull neck appearance, and fatality from airways compromise or toxin-mediated complications. In this picture, you can see tonsillar oropharyngeal diphtheria, localized membranous form, plaques not on uvula, not on soft and hard palate, only in tonsils. It is localized form. In this picture, widespread diphtheria, oropharyngeal diphtheria, widespread, plaque on tonsils, posterior pharyngeal wall, no edema, no non-toxic form. Oropharyngeal diphtheria, toxic form. In this picture, you can see different part of throat in plaque, in membrane, and toxic form characterized by bull neck swelling, bull neck edema. And in this picture, you can see patient with not swelling in neck, with diphtheria, with toxic form diphtheria. In this picture too, patient with toxic form of diphtheria, diphtheria bull neck in this picture. And what else about tonsillar and pharyngeal diphtheria? Neurologic complications may be as follow: parallel the extent of primary infection and are multiphasic enhanced. Hyperesthesia and local paralysis of the soft palate occur commonly. Weakness of the posterior pharyngeal, laryngeal, and facial nerves may follow, causing a nasal tone in the voice, difficulty in swallowing, and risk of death from aspiration. Cranial neuropathies characteristically occur in the fifth week and lead to oculomotor and ciliary paralysis, which manifest as strabismus, blurred vision, or difficulty with accommodation. Symmetrical polyneuropathy begins within 10 days to 3 months after oropharyngeal infection and principally causes motor function deficit with diminished deep tender reflexes. Proximal muscle weakness of the extremities, progressing distally and more commonly distal weakness progressing proximally and described paralysis of the diaphragm can endure. Laryngeal and bronchial diphtheria, it's very severe form because there is obstruction of respiratory ways. In a minority of patients, the larynx is the initial site of infection, the first site of replication, and with initial prosentic symptoms similar to laryngotracheal bronchitis from other causes. Initial hoarseness may progress to loss of voice and severe respiratory tract obstruction. Initially nasal diphtheria may present as a common viral upper respiratory tract infection. Not any specific symptoms initially in the first stages of the disease. Foul odor may develop. This form of diphtheria is most common in infants. Pseudomembranes in the larynx, trachea, and bronchi may slough and obstruct the airways with appearance of a hoarse voice, barking cough, and stenotic respiration. Children, they are particularly prone to airway obstruction because of their small airways. Acute stenosis of the larynx is characterized by a triad of symptoms. The first, hoarse voice, second, a rough barking cough, and third, noisy stenotic breathing with progressive dyspnea or the inspiratory type. Three stages, there are catheteral, stenotic, and asphyxial. In this picture, you can see combined diphtheria in patient, toxic form of the oropharynx, nose, larynx, descending croup, condition after tracheotomy. Cutaneous diphtheria. It is a rare form, but you should know about it. Cutaneous diphtheria may occur at one or more sites, usually localized to areas of previous mild trauma or brushing. It is more common in tropical climates. Pain, tenderness, and erythema at the site of infection progress to ulceration with sharply defined borders and formation of a brownish gray membrane. Local disease may persist for weeks to months. Additional sites of infection have include the external ear, the eye, usually the palpebral conjunctive, and the genital mucus. Rare sporadic cases of endocarditis have been reported, usually due to non-toxigenic strains. Septicemia caused by Corynebacteria diphtheria is rare but universally fatal. Laboratory studies. Diagnostic tests used to confirm infection combined isolation of Corynebacteria diphtheria on cultures with toxigenicity testing. In all patients at whom diphtheria is suspected and in their close contacts, obtain a specimen for the nose and throat, nasopharyngeal and pharyngeal swabs for culture. Isolation of Corynebacterial diphtheria from close contacts may confirm the diagnosis, even if results of culture and specimens taken from the patient are negative. After Corynebacterial diphtheria has been isolated, determine the biotypes, gravis or meatus or intermediate word biotypes. Serum antibodies to diphtheria toxin. Measurement of the patient's serum antibodies to diphtheria toxin before administration of antitoxin may help assess the probability of the diagnosis of diphtheria. If antibody levels are low, diphtheria cannot be excluded. But if levels are high, Corynebacterial diphtheria is less likely to produce serious illness. Medical care. Critical care needs and complications must be addressed. Mechanical ventilation may be inevitable because the combination of waste obstruction by the diphtheric membrane and peripharyngeal edema pose a fatality risk in patients with diphtheria. Specific antitoxin is the mainstay of therapy. It is main part of therapy. Specific antitoxin, anti-diphtheria antitoxin, should be administered on the basis of clinical diagnosis because it neutralizes free toxin only. Efficacy diminished with elapsing time after the onset of mucocutaneous symptoms. Antitoxin is administered once at an empiric dose based on the degree of toxicity, site and size of the membrane, and duration of illness. Most authorities prefer the intravenous route with infusion over 30 to 60 minutes. Antitoxin is probably of no value for local manifestation of cutaneous diphtheria, but its use is prudent because toxic sequelae can occur. Antitoxin is not recommended for asymptomatic carriers. Asymptomatic carriers is treated with antibiotic wide spectrum. In this slide, I want to show you that the dose of anti-diphtheria serum doesn't depend on the age and body weight of the child. Dose of anti-diphtheria serum depends only on the form of the disease, such as in localized form, we administered 15 to 13,000 international units of anti-diphtheria serum. And if we have toxic first, second, and third stages of diphtheria, we should administer 60 to 100,000 international units of anti-diphtheria serum against this disease, against Corynebacterial diphtheria. This dose depends only on the form of the disease. Antibiotic agents, we administer two. Antimicrobial therapy is indicated to halt toxin production, treat localized infection, and prevent transmission of the organism to patient contacts. Corynebacterial diphtheria is usually susceptible to various agents in vitro, including penicillin, erythromycin, clindamycin, rifampicin, and tetracycline. Resistance to erythromycin is common in closed population if the drug has been used broadly. Antibiotic therapy is not a substitute for antitoxin therapy. Elimination of the organism should be documented by at least 2 successive cultures from the nose and throat or skin obtained 24 hours apart after completion of antibiotic therapy. After 24 hours after completion of therapy with antibiotic. Asymptomatic carriers. When an asymptomatic carrier is identified during prophylactic diagnostic, maybe the following steps are taken. Antimicrobial prophylaxis is administered for 7 to 10 days. Individuals are placed in a strict isolation until at least 2 subsequent cultures taken 24 hours apart after cessation of therapy demonstrate negative results. Repeat cultures are performed at a minimum of 2 weeks after completion of therapy in patients and carriers. If results are positive, an additional 10-day course of oral microlyse should be administered and follow-up culture performed. Efficacy of antimicrobial prophylaxis is presumed but not proven. Asymptomatic, previously immunized close contacts should receive a booster dose of the preparation containing diphtheria toxoid, such as DTaP, DT, TDAP, or TD, depending on age. If they have not received a booster dose of diphtheria toxoid within 5 years, immunized children is in need of the 4th dose. Vaccines. Universal immunization is the only effective control measures. Diphtheria toxoid is typically combined with tetanus and cellular pertussis for children. Diphtheria and tetanus toxoid cellular pertussis vaccine, DTaP, such as Infanrix, may be part of routine immunization schedule for infants and young children. Tetanus and reduced diphtheria toxoids and cellular pertussis vaccine, such as Adacel, Boostrix, TDAP, tetanus toxoid, reduced diphtheria toxoid, and cellular pertussis vaccine. There are different type of vaccine, different containing of this vaccine. In Russia, we have 6 doses of diphtheria vaccine for children, and duration of vaccination is 3, 4.5, and 6 and 18 months, and then 6 to 7 years and 14 years. There are 6 doses against diphtheria with diphtheria antitoxin. Vaccines are 1 absorbed pertussis diphtheria tetanus vaccine and 2 pneumococc. In Russian we have 2 different type of vaccine. Only diphtheria, only tetanus, monovaccine, maybe 3 vaccine, 3 components in 1 vaccine, and 4 components such as pneumococc, pertussis, diphtheria, tetanus, and hepatitis B. And there are different others vaccines such as Infanrix Gexa. Infanrix Gexa contains diphtheria, tetanus, pertussis, hepatitis B, and poliomyelitis, and Haemophilus influenza. And we like to use combined vaccine. In this picture, National Russian vaccination plan. Diphtheria in red line, 3 and 4.5 and 5 months. The 3 vaccination, and revaccination number 1 in 18 months, and revaccination number 2 and number 3 at 6-year-old and 14-year-old, and every 10 years since the last vaccination. Different vaccine in this picture: Adacel, Boostrix, and Tdap. Diphtheria toxin contains in this vaccine. Anotoxin. Prevention. What else? Serological surveys demonstrated that 20% to more than 50% of adults lack immunity to diphtheria toxin. In some areas of the United States, with particular low levels among elderly persons, serum antitoxin concentration of 0.01 international unit per milliliter is conventionally accepted as the minimum protective level, and 0.1 international unit per milliliter provides a definitive protective level. Travelers to countries with endemic or epidemic diphtheria should have their diphtheria immunization status reviewed and updated when necessary. Complication: demyelination of nervous tissue is seen in all fatal cases of diphtheria. Frank paralysis occurs in 10 to 20% of patients and most often involves the muscles of the palate and the nasopharynx, beginning as early as the first 10 days of illness. Difficulty swallowing and nasal speech, and often the first indication of neurologic impairment. Involvement of other cranial nerves, which may be delayed until as late as 7 weeks after infection, results in oculomotor paralysis and blurred vision. Involvement of the phrenic nerves may cause diaphragmatic paralysis at any time between the first and 7th weeks of illness. Recovery from urologic damage usually is complete in patients who survive. Cardiac complication may arise during the first 10 days of illness or may be delayed until 2 to 3 weeks afterwards when pharyngeal disease is subsiding. Cardiac involvement is thought to be responsible for 50 to 60% of deaths associated with diphtheria. The first sign of toxin-induced myocardiopathy is tachycardia, disproportionate to the degree of fever. Various dysrhythmias, including first degree, second degree, and third degree head block, atrioventricular dissociation, and ventricular tachycardia can develop, and congestive heart failure may be a consequence of myocardial inflammation. Echocardiography may reveal dilated or hypertrophic cardiopathy. In patients who survive, cardiac muscle regeneration and interstitial fibrosis lead to recovery of normal cardiac function, unless toxic damage has led to a permanent arrhythmia. Airway obstruction by the diphtheretic membrane and peripharyngeal edema combine to pose a risk of death in patients with diphtheria. Prognosis: for respiratory tract diphtheria, their fatality rate can be set at 10 to 15%. Their prognosis depends on multiple factors, including the virulence of the organism, the patient's age and immunization status, the site of infection, and the timing of administration of the antitoxin. In most diphtheria-related deaths, due to complications, mechanical obstruction and cardiac causes are important factors. In this picture, it is infographic about necessary of vaccination against diphtheria. And in this picture, you can see historical moments of create diphtheria serum. And diphtheria is all. Lecture about diphtheria is all. And the second topic today is mumps in children. Mumps in children caused by mumps virus. The mumps virus is a member of the Paramax virus group, and only one serotype is known. Only one serotype of this mumps virus. Before the introduction of the vaccine, mumps parotitis was a common pediatric illness. Children presented with a low-grade temperature and parotid swelling, often bilaterally. The submaxillary and sublingual glands may also be infected in 10 to 15% of the cases. Epidemiology. Although the vaccine was introduced in 1968, it was not universally recommended until 1977. Cases are related to lack of immunization rather than a failure of the vaccine. Spread of this virus is by respiratory droplets. Transmission may occur about 24 hours prior to parotid swelling and 3 days after swelling is gone. There is transplacental antibody protection that lasts 6 to 8 months. Incubation period is 14 to 24 days, with a peak at 17 days. In this disease, long incubation period, you should remember about it. A clinical manifestation. What symptoms? What clinical signs? There is a prodrome of fever, headache, sore neck, and malaise followed by parotid swelling that may be rapid at first and peaks at 3 days. Their swelling is pre-auricular and extends downward to obscure the angle of the jaw and researches the mastoid. The ear is pushed upwards and out. The temperature elevation is moderate and rarely more than 40 degrees Celsius. The swelling lasts about 3 to 7 days. The gland is tender, and eating spicy or sour foods will increase the pain. There may be swelling around the Stensen's duct on the buccal mucus. In this picture, you can see children with mumps on one side. Left edema, you can see. In this picture, patient with both sides of edema, both parotitis, right and left inflammatory in parotid swells. And there is complications different. Septic meningitis, complication which usually is indistinguishable from other viral etiologies such as enterovirus, herpes virus, or pox viruses. Cerebrospinal fluid analysis reflects less than white blood cells, 500 cells per milliliter, with a lymphocytic predominance. Architis, usually in adolescent boys, with the acute unstopped testicular swelling associated with high temperature and pain. Treatment is local support and analgesics. Atrophy of the test in 30%, and 13% infertility rate. Pancreatitis, myocarditis, nephritis, thyroiditis, unilateral hearing loss, eye involvement may be different. Complications. Mumps in pregnant women has been associated with an increased rate of spontaneous abortion, but not with an increase in congenital malformations. Complications may be occur without parotitis. Diagnosis, clinical diagnosis, but may be confirmed by getting immunoglobulin M antibodies or antibody titers 2 weeks after the acute infection. May culture virus from oral secretions, urine, blood, and cerebrospinal fluid. Differential diagnosis with other viruses, parainfluenza, influenza, human immunodeficiency virus, suppurative parotitis, Staphylococcus aureus, calculi of the duct, recurrent parotid swelling of unknown etiology, malignancies of the parotid, and pre-auricular lymphadenopathy. Treatment. Only symptomatic treatment. Treatment of mumps and its complication is suppurative. There are not any antiviral specific drugs against mumps virus. The patient is isolated until glandular swelling subsides. A soft diet reduces pain caused by swelling. Acidic substances such as citrus fruit juice that cause discomfort should be avoided. Repeated vomiting due to pancreatitis may necessitate intravenous hydration. For architis, bed rest and support of the scrotum in cotton on an adhesive tape bridge between the things to minimize tensor or use of ice pick often relieves pain. Corticosteroids haven't been shown to hasten resolution of architis. Suppurative care with analgesics and antipyretics as needed. Symptomatic treatment with warm and or cold compresses over the parotid gland may also be comforting. And outpatient follow-up is indicated for straightforward infections. Immunization. There is live vaccine. Live vaccine usually given with the measles and rubella. Contain three viruses. 2 doses given at 12 to 15 months and 4 to 6 years. 2 doses only. Rarely symptoms following the vaccine. Also cases of parotid swelling 7 to 10 days after immunization have been reported. There is antibody production in greater than 90%, and the vaccine is 97 protective. The patients are contagious for 9 days after the onset of parotid swelling. The use of vaccine after mumps exposure is not effective in preventing the disease. It is all. Our lecture is complete today, and goodbye, dear students.